American communities, but also our fellow brothers and sisters who are Native Hawaiian and also Asian and Pacific Islanders.
Thank you so much for saying that. I think it's important because, thank you for saying that, because I think when we talk about inclusion, we tend to talk about only whether the black, white,
certain
Latino
population
dynamics, right, or how, but we leave out a lot of people. And I think I'm glad that this was our first panel, because I think it's so important that Native communities are included, and Asian American communities are often not, are left out as well. So we have a lot of communities that are not being spoken about. So thank you so much for saying that. I'm gonna come back to you for the last word on this panel. And so just ask you, how can all of this be addressed? And will you take that back to your agency and make sure that the voice is louder in terms of speaking for Native communities and including the trans part of the Native community?
Yeah, absolutely, and thank you, Joy. First thing I'd like to do is ask those American Indians and Alaska Natives who are here in the audience, or if you work for a Native serving organization, to please stand up. I see a lot of them here clustered. Thank you for your work. Really, the key is partnership. So our immediate actions are going to be to take those additional resources that we've received and partner with the National Indian Health Board, the National Council of Urban Indian Health, and to conduct listening sessions so that we can identify those best and promising practices, share, and pull additional information for use by the entire system. So really appreciate everybody who's here, and again, the opportunity to present on behalf of the Indian Health Service.
Thank you so much. Thank you for being here. Let's give this panel a wonderful round of applause. Admiral Wayaki, thank you so much for being here. Ann White, Stephen Barrios, Kendra Becenti, Mick Wagoner, and Mate Jim. Thank you all. Thank you very much for being here today. Thank you. We're going to take another quick break while this panel leaves the stage. Thank you so much. Cheers.
You have to get out in the streets, and you have to let people know that are not living with HIV how important it is that they be in this fight. We got to get folks like faith leaders in this, because if pastors say it, then it must be true. So we got to get faith leaders in on this so they can realize that HIV is truly a social justice issue. And if we look at it from that perspective, I think folks will be more willing to realize that, I have a vested interest in this.
Okay.
Back to USCA Live in 5, 4, 3, 2, 1. Go, Joy.
All right. Welcome back, everyone. You guys aren't tired yet, are you? You seem a little sleepy. You all right? Good. Excellent. All right. I want to introduce a man who needs no introduction in the HIV community, Dr. Tony Fauci.
Hi.
Thank you very much for being here.
My pleasure.
And so just tell us what is happening? What is the status of trying to end the domestic HIV epidemic? What is going on? What are you doing as a part of it?
Well, the reason we're able to do this is probably most people in the audience know that right now we have the tools that we didn't have years ago that if implemented properly, we could actually end the epidemic. And some people think that's pie in the sky, but it isn't. It's realistic. As Bob said, it's no longer aspirational, it's really reality. The reason is we know the facts now that we didn't know before, that if you treat a person who's HIV infected and bring down the level of virus to below detectable level, not only do you save that person's life, but you actually make that impossible to transmit to another person. So theoretically, we live in a real world, but not a theoretical world.
Right.
Theoretically, if you were to get everyone who is a person with HIV and get them access to care and put them on therapy and not only save their life, but prevent them from infecting others and get PrEP for those who are at risk for HIV infection, theoretically, if you did that, you could end the epidemic tomorrow.
So we want to make sure, right, the terminology we're using is people living with HIV.
Right.
We're just being careful about that.
Okay.
So that I do want to ask a couple specific questions. One is about PrEP. So during the protest, one of the issues that was brought up was that first, it's quite expensive.
Right.
That people are not able to access it because they don't have the money, which seems criminal that people can't access it. What is being done on a national level to make sure that PrEP is available to everyone who needs it?
Yeah, I think not enough. I mean, as far as I'm concerned, we should get PrEP to everyone who needs PrEP. And there are now, if you look at the differential between the people who are at a sufficient enough risk that they would benefit greatly and prevent getting exposed and infected.
Is it covered by insurance?
You know, in some respects, yes, but people are uninsured who don't, and then there's co-pays that get in the way.
Right.
So we need to do better to make PrEP much more readily accessible at as low a price as possible. Personally, I'd like to have it be no price.
Right. It shouldn't, right. Because it is a potentially life-saving drug. Is there a generic version of it? Is there an attempt to create lower cost versions?
Yeah, there certainly is a generic version of it. And in fact, there are other drugs, if you look at them, they may be as good as the classic PrEP. So there are ways to get around this.
Let's talk about the other issue that I had not heard about before, the idea that in attempting to study and create the database to understand where HIV is more prominent, where it's more prevalent, the collection of molecular HIV data, sometimes without the knowledge of people, and having that data then used without people's permission, and tracking people. Because we do know that we are living in a time when communities who are already vulnerable are even more vulnerable, whether it's people who are undocumented, whether it's people who are transgender. It's not a really safe time for people. You don't feel safe. So what do you make of this idea that people are being tracked and put into databases without their knowledge?
You know, I don't think that's happening, but it certainly can happen theoretically and maybe in reality. I totally understand the concern people have about data related to them, themselves, the virus. Anything that could be used against them is something they're concerned about. I have complete empathy with that. So if that's going to be done for the purposes of public health, to understand how an epidemic is essentially evolving, that has to be done with the absolute protection of privacy of people.
Is this something that you would support seeing congressional hearings on? Because this seems to be a pretty important
I don't know if you want to call it a congressional hearing. You might get nothing out of a congressional hearing. I would support doing something about it.
Fair. Absolutely fair. One of our previous guests talked about there being fewer than 60 communities where the concentration of people who are newly living with HIV are. And what is being done to make sure that those communities are being really focused on, and what's being done? If they know where the communities are.
You know, that's part of the plan. I mean, Bob had mentioned it. If you look at the map of the United States, these little boxes, there are 3,007 counties in the United States. If you look at that, more than 50% of all of the new acquisitions of infection are occurring in 48 out of 3,007 of those counties, plus the District of Columbia right here, plus San Juan, Puerto Rico, and in several rural states. So that's terrible that there's that concentration, but from the standpoint of what you can do about it, it makes it a very accessible way to implement the plan. Because if you could focus, not to the exclusion of the other areas, but if you could focus on areas that are the drivers, you just think about that, 50% of all of the new infections come from 48 plus 2 out of 3,007. That was one of the things when Bob and I saw that data, we said, wow, this is something we need to jump all over. So that's what we're talking about, at least part of the implementation.
How confident are you in this administration being able to pull off a plan to reduce the number of people who are newly living with HIV, to deal with the HIV epidemic, when they're having so many challenges with, for instance, the treatment of trans people, the treatment of undocumented people? It's not clear to me that they would be doing aggressive prevention within these communities. But communities of color don't feel like they're doing much for them at all.
Well, you're using the word administration versus, I mean, Bob and I are the people who are going to be doing it. The people in the CFARs, the people who are in the community are going to be doing it. We're going to be doing it. Not any whatever the administration is, we're going to be doing it. So I have the confidence that with the will and the energy and the commitment of what we have and what the people in this room have, it's going to happen.
How do you get to the people who have fallen out of care? It's an estimate, I think the estimate here is 250,000 people who have fallen out of care altogether. How do you reach them?
Well, I mean, if we knew how easy it was to reach them, you wouldn't be asking me that question.
Fair question. Yep, fair
I
point.
mean, obviously, it's not easy to do, and that's the reason why having accessibility of health care for everyone is a very important thing.
Yeah.
And that's the thing we have to have.
Is there a specific target within this plan to deal with the trans community? We've had a couple of questions.
Yeah,
come
oh,
up.
absolutely. In fact, we explicitly talk about that and act on it every time. We know the people who clearly are the most vulnerable, and clearly the trans persons are among those, and they're ones that we need to reach out to.
Can you speak specifically about the undocumented? Because this is an issue that's fairly alarming, that people's HIV status is now becoming a factor in whether or not they can apply for asylum and remain in the country. And also the question is, are people being treated? Are they receiving treatment when they're in government detention, in which they are the government's responsibility at that point?
I mean, that's not anything that I have control over,
Sure.
but as a physician, a scientist, a public health person who's been involved in this from the very first day, I think anyone who is either at risk or a person with HIV should have accessibility, no matter who they are, where they come from. All those things don't matter to me.
Yeah, yeah.
Right.
And if not, what are the risks of not doing that? Because it does seem to me that there's a public health risk if
Well,
if
there's
people are
also
being ignored.
humanitarian risk
Clear.
in addition to the public health
Absolutely,
risk. Right.
absolutely. Is there a specific part of this plan that will?
I bet you never had rapid questions like this before, did you?
Well, people are usually not so succinct. You're not filibustering, which is bizarre.
That's right. I'm easy. I'm quick.
This is not like debating, interviewing a politician.
Go ahead.
The answers would be 5 minutes, so this is good.
Yeah.
We're getting more in. What about the Latinx community? What is this?
The
what
what?
are the Latino community?
Yeah.
What are the specific parts of the plan that will target people in Latino?
Well, it's explicitly said, and not only said, but understood. If you look at the most vulnerable of people of acquiring HIV, clearly, men who have sex with men, fundamentally African American men who have sex with men, Latinos, transgender persons, those are the ones that are the most vulnerable and most at risk. Those are the ones you have to concentrate on. That is part
And black
of-
women too.
Yeah, of course.
Yeah. And I'm sorry, somebody was asking a question there. So, can you just give us a 1, 2, 3? Because a lot of the people here are going to be working on implementing this
Right.
this plan. If you could just give us a very simple, this is what this plan is. You're succinct, so you can make it simple.
Yeah, it's implementation. When people ask the question about, for example, what the role of the NIH is in this.
Sure.
I mean, the CDC is fundamentally a phenomenal public health organization that implements. They deal very, very closely with people at the community level, the state, the city, the local public health officials.
Yeah.
One of the things that we do as a scientific organization is what's called implementation science, which means we try to make sure that we follow in real time what's going on, learn from the mistakes, because this is a 10-year plan that is a big undertaking. We are not going to get it right the first month, the first year, or the second year. We need to do better and better and better and learn by what we didn't do as well as we could have done. And things that do work, make sure we concentrate on that. That's the kind of thing. This is implementation.
Right.
We have the tools that we need. We need to implement them. And in order to implement them, we've heard it multiple times so far this morning and early afternoon, is you have to get the community involved, because implementation from the top, down, it's important, but it doesn't work until you absolutely get into
In
the
the
community.
communities. Dr. Tony Fauci, thank you very
Yeah,
much.
you're welcome.
Thank you very much for being here. Let's give I'm just calling him Tony like we're old friends. Dr. Anthony Fauci, thank you very much for being here.
Okay.
Really appreciate it. Okay, I think we're taking another quick break so you can watch another fabulous video.
Reach people who are outside of care or who don't know their status, I think we have to think a little bit more broadly about who we include socially. And so these are people who are our neighbors, our coworkers, our friends, maybe even our family members who society just hasn't thought of or doesn't oftentimes think of. And so continuing to think about our policies and organizational leadership to make sure that these communities aren't being left out when we're thinking of new programs or we're writing our policies. And so really social inclusion, I think, and making sure we're truly including everyone is how we'll get to those people who, again, often lived on the margins and don't have access to the resources necessary to stay in care or know their status.
Going live in 3, 2, 1, go Joy.
Welcome back. All right. I'm going to introduce my next panel. Tori Cooper is a staunch advocate for the transgender and HIV communities. I'm making sure I'm introducing everyone. And she is the executive director and founder of Advocates for Better Care. Give her a wonderful hand clap. I don't know if I have everyone here. Yeah, exactly. I think don't have everyone. Leandro Rodriguez, raise your hand. The Director of Programs at the Latino Commission on AIDS. And my producer, I don't have all of the pages here, so I don't have everyone's names. I don't have everyone's names. So if you guys could get me a complete list of everyone who's here. Maybe y'all should just tell me who's here, because I don't have everyone's names. So while I wait for those names, let me just go ahead and start with Tori Cooper. And we've had a couple of questions from the audience talking about specifically the challenges that the transgender community has had to deal with in terms of dealing with HIV. Please tell us what those challenges are from your point of view, particularly for transgender people of color.
So thank you so much, Joy. It's important to remember, very first of all, that people of color is a public health term that includes every person other than white people. So when we're talking about public health and we're talking about communities of color, it's important to remember that from a public health standpoint, Black people have the highest risk of HIV of all people of color. There's not an Asian trans woman, there's not a Latina trans woman that has the same risk of HIV infection as I do. So I always like to make sure that people understand that, because Black transgender women have the highest risk of HIV of any demographic category in the United States, period. So, would you repeat the second part of the question, please, Joy?
Yeah, well, my question is, what would be your prescription for what to do to change that?
So I wish I could answer all that in 90 seconds, but I can't. But one of the very first things, so can you all see me? So I'm a trans woman, a dark-skinned trans woman wearing an orange dress with polka dots on it. However, there's some healthcare providers and entities that believe that they can't see me. They say we don't exist, that we're unicorns or invisible.
Yeah.
So one of the very first things I think that is necessary is to actually engage transgender people in saving our own lives. Mm-hmm. Make sure that you're equipping us with all of the tools that, I almost said white man, but make sure that you're equipping us with all of the tools that every other category of people have gotten to help to save themselves. Mm-hmm. And then make sure that you're compensating us in an equitable way to do the work.
Thank you very much for that. And I introduced Leandro Rodriguez. I'm going to go next, the Director of Programs at the Latino Commission on AIDS. The same question for the Latino community, the Latinx community, particularly for Latinx gay men, and talk about the challenges in getting people to know their HIV status and being able to access drugs like PrEP and drugs like Truvada and other drugs for treatment.
All right. Well, buenas tardes, Joy. Buenas tardes.
Buenas tardes.
Very happy to be here. This is a full circle moment for me. Since we're honoring Dennis De Leon, he was the last person who made it possible for me to move to New York. So this is dedicated to him. 3 things to address your question. With that hostile rhetoric of public charge against Latinx immigrants, with a government that is describing Latinx individuals in very inappropriate ways, there's fear. And I think it doesn't matter how powerful the science is, if there is fear in the community, people will not access treatment. People will not access the medicine. So in order to address that fear, clinics, community-based organizations, mobile units, universities, everyone that come in contact with the community has to create a safe space. And I know this is a cliche, we've heard about safe spaces before, but I want you to think about this. If you're an immigrant Latinx person and you're being taunted by social media on public charge, where it says that if you can access help, that might impact you negatively in your citizenship, what is it that you're going to choose? So creating a safe space doesn't mean just putting a poster or just having a poster in Spanish, because by the way, Latinos speak a lot of Spanish in different dialects. It doesn't just mean hiring Latinos to work at the agency, those are elements, but it really goes, on my invitation for you all is to really look at the organizational infrastructure, culture, and climate to ensure that we're creating safe spaces. In particular to the Latinx, gay, and LGBT community, I think it's enough to have interventions that just teach you how to use a condom. For the past 20 years, I've been more interested in the decision of why people don't use the condom. Just teaching people or showing a video, this is the 10th step of how to use this, it's not just enough. There's internalized homophobia. There's internalized transphobia, biphobia, self-esteem issue, social isolation, especially if you're coming to a place and you need to navigate the language and the culture. We need to have interventions that allow for these dynamics to be addressed and resolved. Third, to speak on cisgender women and men, in my experience, I've observed that the HIV prevention message have always been one-on-one. And I'm not here to criticize that. I'm just here to say that for Latino culture, we have to include the family. We have to include the social network, either the family that you're born with or the family that you choose. HIV prevention is not just one-on-one. We have to include family in those interventions. And I would just like to say to all our Latinx brothers and sisters that you're not alone. We stand together. A nuestros hermanos latinas y latinos no están solos, pero tenemos que estar unidos. Thank you.
Thank you. All right, Nishi Parkinson, wave. Okay, there you are right there. A woman living with HIV who's part of the Positive Women's Network. So, and I'll throw the same question to you because we know that Black women, of course, are also one of the largest groups of people living with HIV. What do you want to see happen? What do you want to see change in the way that we as a society, the way that governments and institutions are dealing with this issue for Black women?
As we've already mentioned throughout the afternoon, have available her stories such as me. I'm a living testimony of 22 years, and in my community, when I was diagnosed in 1997, I did not have anyone that looked like me. The first people that embraced me was white and Black gay men. We need women to challenge themselves, to remove the stigma, to remove the isolation in the communities that we live in. 1 out of 5 new infections are women. 20% of all of those women are women of color. What are we going to do about it? We're going to fight back. We want to include it of our families, our friends, and our relatives to walk that walk with us daily. We need more social media coverage from a Black woman. Most of the commercials and things that we see throughout our Gilead and our Janssen and our ViiV pharmaceuticals, they do not represent who we are inclusive. We're asking for our funders to put more money into the Women of Color initiatives around the world globally so that we can stand in safe spaces and be meaningful involvement of women living with HIV around the globe. Our voices are being heard through PWN, USA, and that's the reason why I'm here today. I am the face of HIV. I am the face of my community. I'm a face of the Black community, the Black woman community, and I really think that the community and the global community needs to hear us more. We are available, we are here, and we want to act now.
Thank you. All right, I'm going to now introduce Hill Jones, who I don't have a full bio for, so please tell us about what you do and then tell us what you believe you want to see. What do you think should be done in terms of dealing with the issues surrounding HIV? And I apologize, I don't have your bio.
Thank you so much, Joy. My name is Venton Hill Jones, and I'm the Chief Executive Officer of the Southern Black Policy and Advocacy Network. Thank you. And part of our work is really focused on engaging Black public health leaders to be able to have a more meaningful involvement in health equity policy work. And that work started with addressing HIV policy work. And so as we talk about the work, I have 3 recommendations, particularly focused on Black people in the South, but really particularly focused on the needs of young Black gay men. And so 1, I think we need to strengthen culturally competent systems of healthcare delivery. Providers are still challenged with serving the diverse needs of people living at the intersection of being Black and LGBT. Also, number 2, build the public health leadership pipeline. We are more than community. We are more than just people living with HIV. We are the public health workforce that's working to respond to this epidemic. It is not okay to just bring us to meetings and give us an honorarium and send us back home. And when we talk about the public health workforce, funding must also be directed for workforce development, providing degrees, certifications, and other resources to facilitate active engagement in planning councils, community planning groups, and other forms of youth development. We have programs like the Youth Scholars and different programs, but when the conference is over, what additional certifications are they using so that they can continue to have long-term impact in addressing the epidemic versus being discarded at the age of 30? And last, I think it's very important as we have this conversation about cultural competency is to understand that Black gay men and Black trans women are Black people. And we have to make sure that efforts to address the needs of Black people include us. We cannot just be grouped in groups of MSM and not in the Black conversation. Ultimately, I think that we need to mobilize young people to speak and lead on behalf of young people. We cannot just continue to be brought into the room to disclose our HIV status over and over again until you're tired of hearing it. And so, I'll stop there. Thank you so much.
Thank you very much. Thank you very much. Venton Hill-Jones, thank you very much. I know who you are now. Thank you very much. All right, finally, I want to bring in Dr. Laura Cheever. And Dr. Cheever is the Associate Administrator for the HIV/AIDS Bureau in the Health Resources and Services Administration. So if you can sort of give us, kind of wrap this up for us, because we've talked about the need to have non-clinical approaches because there is stigma associated with attempting to, access clinical resources, and there's also lack of access. People sometimes don't have health care, and so they're just struggling to be healthy, period. What would you, in sort of wrapping this up, say would be the most useful and effective ways to deal with all of these various communities with, a succinct and smart public health policy? What would you suggest?
Yes, that's a great question. At HRSA, we administer the Ryan White HIV/AIDS program, which has been really effective. We provide services over half of all the people living with diagnosed HIV in this country. That's over 500,000 people. And most of those people are living below the federal poverty level. Most of those are people of color. And because we have an integration of both healthcare and support services, like assistance with housing and food and childcare to get to medical appointments, transportation's been key. That program's been incredibly effective. Of people that come into care, it's 86% are virally suppressed. The challenge is that we have about 400,000 people in this country who are not in care. And why they're not in care are many of the reasons we have been discussing here today. Certainly issues of poverty and discrimination and stigma are huge. Housing is huge, racism is huge. And so in order to address those issues, we need to be providing services differently. And I think we've been hearing about that all along. We need to be figuring out how do we deliver medical care differently to those 250,000 people that have been diagnosed, and many of them linked to care and have not returned to care. Something happened in that healthcare interaction. Sometimes there was a transition in and out of prisons and jails. Are those people just discarded? How do we interact and how do we engage people starting at a different place in order to get them into care and get them into a care system that's going to work for them? Yeah. So it is about treating people differently. Of the people that are coming into care, 14% are not virally suppressed. That's a huge problem. Those people are coming in to get services, and yet their needs are not being met. So we need to really manage our system differently in order to reach those people, and I know we can. We have excellent examples throughout this room of people that have done things at a very small scale often, have not been able to scale up because we have not had funding. Yeah. Now we will actually, for the first time in many years in Ryan White, have new money The first year, a modest amount, $70 million, but an amount, to do things differently. So that money needs to be used differently to reach the people we haven't reached. And from there, as we continue to hopefully get increases in the appropriation for this, we will be able to do much more by doing things differently to reach people differently.
Thank you very much. Dr. Laura Cheever. Can we give this panel a round of applause? I've gone overtime. I apologize to the producers. Dr. Laura Cheever, thank you so much. Venton Hill-Jones, thank you so much. Tori Cooper, thank you so much. Leandro Rodriguez, thank you so much. Did I get everyone? Oh, and Nishi Parkinson, thank you so much. Did I pronounce your name right? Nishi Parkinson. Thank you guys so much. Did you guys learn a lot today? I did too. I definitely did too. I want to thank all of my guests. Thank you all for having me here. This has been really educational for me. I'm going to take what I learned back home to my shop at 30 Rock, and we'll be hearing a lot more about this. Thank you guys so much. And I appreciated the opportunity to learn about the federal plan to end the HIV epidemic. And I also want to say that I really appreciate you guys. Thank you guys for your patience with the microphones and with me. Thank you all very much. Cheers. Have a wonderful rest of your session. Thank you.
Good afternoon, ladies and gentlemen. Thank you so much for coming to the opening lunch plenary. Desserts are available downstairs in the exhibit hall. Afternoon sessions are beginning soon. Please come to the welcome reception tonight in this ballroom, 6 p.m. to 9 p.m., hosted by the DC Host Committee. Again, thank you all so very much. Have a great day at USCA.